Before I start discussing the abnormal case, let's look at this normal CT to talk about a few important anatomical points. On a normal CT of the brain, the darkest thing you'd see is the CSF, such as the CSF within the ventricle. This ventricle is the lateral ventricle. On a normal CT of the brain, the white matter would appear relatively dark as well. This is compared to the gray matter. The more bright gray matter could either be superficial, such as the cortex, or deep, such as these structures here. What we want to concentrate on today for the sake of the discussion case would be those deep gray matter structures. So from anterior to posterior, the first thing you'd see is this nucleus here of gray matter. This is called the caudate nucleus. Lateral to that and more posteriorly, you'd see this larger nucleus, which is called the lentiform nucleus. The lentiform nucleus is composed of two parts which are difficult to differentiate on a CT scan, the inner globus pallidus and the outer putamen. Going more posteriorly, you'd see another focus of gray matter. This is called the thalamus. You may have noticed that these nuclei are separated by tracts of white matter. This tract here is called the internal capsule. A lateral tract of white matter that separates the lentiform nucleus from the insula or the cortex is called the external capsule. The caudate with the putamen, the outer part of the lentiform nucleus, is actually called the corpus striatum. Now that you know the anatomy, let's go back to the abnormal case. There is a bright hyperdense abnormality that you could easily locate within the thalamus. Important things that appear dense on a CT scan would include intravenous contrast enhancement, acute hemorrhage, and calcification. So this is a hemorrhagic focus that is acute within the right thalamus. Compare that to the normal left thalamus. Given the patient's known history of hypertension and acute presentation, this represents a hypertensive bleed. For a comprehensive differential diagnostic list for acute intraparenchymal brain hemorrhage, please visit our quick case number 2 on Radiology Bit's YouTube channel. Now let's give a few points for the senior residents. The most common location for hypertensive intracranial hemorrhage is that at the junction of the putamen with the external capsule. The area of putamen and external capsule junction is called the striatocapsular region. Remember that the name comes from the corpus striatum, which is composed of the caudate and the putamen, as well as the adjacent external capsule, striatocapsular. Now that we know this fact, have you noticed the area of linear encephalomalacia on the left side in the striatocapsular region? Both an old infarction or hemorrhage may lead to an area of encephalomalacia. So knowing your anatomy and the common location for hypertensive hemorrhage, you'd call this an area of remote hemorrhage rather than an area of remote infarct. The striatocapsular region is the commonest area for hypertensive bleed. The second commonest region for hypertensive bleed is the thalamus, as we see here. The third common region for hypertensive bleed is in the brainstem, namely the pons. This is followed by cerebellar bleeds and lobar bleeds higher above. So we learned a few things from this case, a few points that are directed to juniors and others for seniors. Juniors, remember that on a CT scan, the gray matter, whether superficial, which we call cortex, or deep, which we call the basal ganglia, is relatively dense. Also remember the internal anatomy of the caudate nucleus, lentiform nucleus, thalamus, the internal capsule, and then the external capsule. Additionally, things that could appear bright on a CT scan include contrast, calcium, or hemorrhage. For seniors, remember the area that is in between the putamen and the external capsule is called the striatocapsular junction. Also remember that the commonest location for hypertensive bleed is typically the striatocapsular junction. This is followed by bleeds in the thalamus, pons, cerebellum, or lobes. So this was a longer case where I tried to satisfy the needs of both the senior and junior followers. More cases later. Thanks for watching. This is a sagittal T1 of the thoracic spine. T1 is known by the dark appearance of the CSF fluid. And this is a T2 weighted MRI from the same patient. Notice how the fluid, the CSF surrounding the spinal cord, is bright. Have you noticed anything that is strikingly abnormal on this MRI? Before we proceed, let's look at this normal case. So this is a normal T1 image. This is a normal T2 image as well. A small piece of information, we have what's called red marrow versus yellow marrow. To simplify the difference, red marrow is more vascular versus yellow marrow, which is more fatty. This is our normal T1 image. This is a normal vertebral body with an intervertebral disc. No matter what type of marrow you're looking at, the general rule is the marrow should be brighter than the disc on T1. Now let's go back to the abnormal case. Notice how the marrow is low in intensity throughout the spine. Compare that to the intervertebral disc. Remember, the marrow should be higher in intensity compared to the adjacent intervertebral disc in normal patients. Here the relationship is reversed. This is called the bright intervertebral disc sign, and it's a sign of marrow abnormality. So what is the differential diagnosis for diffuse low signal intensity of bone marrow? Low signal intensity of the bone marrow could be a response to chronic anemia, such as sickle cell anemia or thalassemia. Low marrow signal intensity could also result from malignancies such as metastasis, myeloma, lymphoma, or leukemia. In addition, bone sclerosis would decrease the bone marrow signal intensity on MRI. Examples would include sclerotic metastases and osteopetrosis. Bone marrow proliferative disorders such as myelodysplastic syndromes, myelofibrosis, and mastocytosis might also result in the same thing. This is the CT scan on the same abnormal patient, showing bone expansion and coarse trabeculation without focal lesions or cortical thickening. This is characteristic of thalassemia patients, which explains the low signal intensity of the bone marrow on MRI. So the first teaching point is that the marrow should always be higher in signal intensity compared to the disc on a T1 weighted acquisition. If you see the opposite on a T1 image, that's called a bright disc sign, and it denotes bone marrow abnormality. The second teaching point is to remember the differential diagnosis of diffuse low signal intensity of the bone marrow on T1. The differential diagnosis could be remembered under these four big categories: chronic anemia, malignancies, myeloproliferative disorders, and sclerosis. The final teaching point is to remember the appearance of thalassemic bones on CT as bone expansion and coarse trabeculations. Thanks for watching. More cases later. You probably have noticed the bilateral pleural effusions and are questioning these linear opacities as either scarring or atelectasis. However, don't let the obvious abnormalities distract you. You should always look at hidden areas on every single chest radiograph. Remember that the tracheal air column should be well centralized in a patient who is not rotated. If you follow the trachea here, it appears normal, but as you go below, it is substantially deviated to the right side. Compare that appearance to this normal case. Notice how the trachea has a central course without deviation to the right or to the left. In a normal case, you may allow a little bit of impression from the left side of the trachea by the effect of the aortic arch, especially in elderly or hypertensive patients. Let's go back to the abnormal case that we started with, and now we could look at the lateral chest radiograph. The lateral chest radiograph makes it easier to detect. You have to have a lucent area in the retrotracheal region, which is not the case here. A normal retrotracheal space should be as lucent as a normal retrosternal space, so compare the density here with that there. Another hint of abnormality on this case is that the trachea is deviated anteriorly. Now a bit of discussion for the seniors. The retrotracheal space is bounded by the trachea, the aortic arch, and the spine. So the differential diagnosis of something that fills the retrotracheal space would depend on these anatomical structures and what lives in the space itself. Tracheal neoplasms may give you a retrotracheal opacity. Vascular abnormalities such as an aortic aneurysm or an aberrant vessel may also fill the retrotracheal space. Remember that the esophagus lives in the retrotracheal space, so esophageal tumors or duplication cysts is an important differential diagnosis. Abnormalities extending anteriorly from the spine, such as metastases, could also give you filling of the retrosternal space. So don't forget a spinal or paraspinal abnormality as a potential cause for retrosternal filling. Lymph nodes also live in the retrotracheal area, so lymphadenopathy from an infection, neoplasm, or reactive etiologies is a differential. Remember that TB, lymphoma, and metastases are common etiologies for lymphadenopathy anywhere. Finally, don't forget that processes extending above from the neck into the retrotracheal space are also common. Abnormalities that could extend from the neck above into the retrotracheal space below would include thyroid enlargement. Other extending lesions would include that of fluid-containing abnormalities such as hematoma or abscesses. And in the pediatric population, remember that cystic hygroma or lymphangioma could extend from above into multiple spaces within the chest. Here's the CT on the same patient, showing that the lesion is continuous with the left thyroid lobe, has the same attenuation and calcifications. The abnormality also shows extension into the chest in a retrotracheal location, severely compressing the esophagus. For the seniors with such an abnormality, don't forget to comment on the effect on the airway, on the esophagus, on the adjacent vascular structures. Also remember to comment on the mediastinal fat. If there is any associated infiltration of the fat, that might be a worrisome sign. Look for the presence or absence of adjacent lymphadenopathy, and if the abnormality has invasive features into the surrounding structures. The first thing that we learn from this case is that we should not be distracted by obvious abnormalities. You should have a systematic approach and look at all hidden areas. We also learned that the trachea is a hidden area and it should have a central course in a patient who is not rotated. We also learned to look at lateral chest radiographs to confirm the frontal chest radiographic abnormality. We also had a quick discussion about the retrotracheal space and lesions that may occur there. So the big categories here are tracheal, esophageal, vascular, bone, lymph nodes, and descending from above. A neat teaching point from the CT scan as well is that thyroid extension is not necessarily anterior, it could be posterior to the trachea. And since thyroid abnormalities could extend anterior or posterior to the trachea, don't be surprised if you have what looks like a circumferential thyroid abnormality. Finally, we talked about important things to mention in the report. The effect on the airway, esophagus, and vessels is important, lymphadenopathy, and invasion. That concludes today's case. Your comments would be much appreciated. Thanks for watching, and more cases later this week. I'm only showing one image today to convey a very important teaching point. One of the things you'd look for in a case of trauma is injury to the aorta. Generally speaking, acute aortic injuries are divided into those caused by trauma and those that are non-traumatic in nature. Non-traumatic acute aortic injuries unrelated to this case include aortic dissection, intramural hematoma, penetrating atherosclerotic ulcers, and bleeding aneurysms. The reason I mention those possibilities is to be very clear that traumatic aortic injury is unrelated to these conditions. In this case of trauma, radiology residents may have noticed by now that there is an abnormality at the proximal descending aorta. The abnormality is in the form of an irregularity at the inferior border of the proximal descending aorta. Although this looks like a flap, this should not be called an aortic dissection. Aortic dissection is a non-traumatic acute aortic injury caused by hypertension, and it's classified into two types. Type A, where there is any kind of involvement of the ascending aorta, and type B, which is isolated to the descending aorta. Compared to type A, which is a surgical emergency, type B could be treated conservatively with controlling the hypertension. So if you call this a type B dissection by mistake, the patient might take the wrong pathway, since traumatic aortic injury should be treated immediately. I will repeat to emphasize the point. Traumatic aortic injuries should be treated immediately, no matter what location you find it at. So the more proper term to use in the context of trauma would be aortic transection, laceration, pseudoaneurysm, or just call it traumatic aortic injury. Now, a little bit of theory that's useful for both seniors and juniors. It is famous that the most common location for traumatic aortic injury is in the proximal descending aorta in what's called the aortic isthmus. This is the part of the aorta immediately distal to the origin of the subclavian artery, which we don't see here. However, according to some references, this is not true. The most common location of traumatic aortic injury is actually in the aortic root. The reason books don't mention this is that because patients who suffer aortic root injury unfortunately die at the time of the accident. So the commonest type of injury is probably at the aortic root. The second commonest type is at the aortic isthmus, and that's the type you're going to see at the hospital. The third site of injury is at the diaphragmatic hiatus. Notice that these three areas of the aorta are relatively fixed, and that's why they're affected by severe acceleration-deceleration injury. The aortic root is fixed at the heart, the isthmus is fixed at the ligamentous arteriosus attachment, and the descending aorta is fixed at the diaphragmatic hiatus. So what have we learned from this single sagittal contrast-enhanced CT aortic angiogram? We learned a bit about the types of traumatic versus non-traumatic aortic injuries. We touched on aortic dissection, knowing that it's related to hypertension, non-traumatic, and has two types. We talked about the common locations of aortic injuries in trauma and discovered that aortic root injury is very common and patients unfortunately die at the site of accident. Finally, acute aortic injuries are not dissections, and if they occur at any site of the aorta, they require immediate treatment. I will try to show more aortic pathology in future cases. Thanks for watching. Your comments are appreciated as usual, and see you later. You probably have noticed this ill-defined opacity along the medial aspect of the lower lung. However, this patient is asymptomatic. One consideration would be pneumonia. This would be very unusual in a patient who does not have symptoms. Another consideration for this abnormality would be collapse. With collapse, you'd expect volume loss and shift of structures to the right side. You might be thinking that the opacity obscures the right cardiac border, creating a silhouette sign and denoting a right middle lobe opacity. This case is none of what we mentioned. So let's go over the findings. Although there is a clear-cut opacity and questionable L definition of the right cardiac border, the lung markings are clearly seen through this abnormality. The second observation is that the cardiac structure is shifted to the left side rather than being shifted to the ipsilateral side. The third observation is that despite the apparent shift of the heart, the mediastinum is well centralized. Now, another more subtle finding is the asymmetric orientation of the anterior ribs. Normally, the anterior ribs are less dense than the posterior ribs and they are more difficult to see. The anterior ribs also have a normal oblique course. Compare the ribs on the left with those on the right. You'll notice that the right-sided ribs have a more oblique course. So to know what's happening in this case, let me show you the lateral chest radiograph. And now the diagnosis is more clear. This is the sternum, which has a posterior orientation. We know that a posteriorly displaced sternum is called pictus excavatum, compared to one that's displaced anteriorly, which is called pictus carinatum. So in this asymptomatic patient, the diagnosis was pictus excavatum. It was not right middle lobe pneumonia or collapse. On frontal chest radiographs, pictus excavatum is a famous pitfall for right middle lobe pathology. Of course, examining the patient would make this less of a pitfall. However, when you read a chest radiograph, you usually don't have the patient around. To avoid such a mistake, always keep in mind that pictus excavatum may mimic right middle lobe pathology, then try to look for secondary findings. To summarize the findings, pictus excavatum has the following: an L-defined opacity along the right cardiac border, possible obscuration of the right cardiac border, deviation of the heart to the left side with a maintained centralized mediastinum, a more acute oblique course of the right-sided anterior ribs compared to that on the left, and of course, it's an easy diagnosis by looking at the lateral chest radiograph. We learned today that pictus excavatum may mimic right middle lobe pneumonia or collapse, and we also learned how to look for secondary signs of this condition. Thanks for watching.